On tonight's episode of the Dads and Angels podcast, I sit down with Professor Michael Murphy. Mike is a professor of transfusion medicine at the University of Oxford and a specialist in the area of NAIT. I hope you enjoyed tonight's podcast, and thank you for listening. All right, Mike, and we're live. So, we started talking earlier. We kind of dove right into things, but before we go into, the really nitty gritty, can you give us like a brief overview of what NAIT is and,
Sure.
kind of, the inner workings of it?
Yeah. So NAIT stands for, what it means is Neonatal Alloimmune Thrombocytopenia. So that's NAIT. Neonatal Alloimmune Thrombocytopenia. And what happens is that the mother makes antibodies, so her immune system attacks the baby, and particularly the baby's platelets. So platelets are little blood cells that are very important for stopping bleeding. So we all have three types of blood cells: the red blood cells that carry the oxygen around, the white blood cells that fight infection, and platelets stop bleeding. And what happens in NAIT is that the mother's immune system recognizes the baby's platelets as something different to her, and she makes antibodies against the platelets. And those antibodies can cross back into the baby's circulation and destroy them. And so the baby's platelet count goes down, and that puts the baby at risk of bleeding. And the bleeding can occur during pregnancy or at the time of delivery or after delivery. So coming back to neonatal alloimmune thrombocytopenia, thrombocytopenia is just a long word for low platelets. Neonatal means baby, so NAIT is usually found shortly after birth, as we'll come on to a bit later. And alloimmune means that the individual, the mother in this case, has made antibodies against something that's different to her. So neonatal, baby, alloimmune, antibodies against somebody else, thrombocytopenia, low platelets.
Gotcha. And so now what are the causes? Because there's a serious amount of discussion about incompatibilities between partners. What's the underlying cause behind how NAIT occurs?
Yeah. So what has happened, what happens in NAIT is the baby inherits from the father a platelet protein that the mother doesn't have. So we all have, so I think that an easy way of thinking about it is that we all know about blood groups. So we all have our own blood groups. So those are blood groups on red blood cells. But platelets have their own set of blood groups. And the mother is lacking a platelet blood group that her partner has and that the baby has inherited from the father. So the mother can recognize the baby's platelets as something different because the baby has this different platelet blood group to her, and she can recognize that as something different and make antibodies against it.
Right. So that kind of ties back to the whole alloimmune part where the antibodies start developing, and that's when the body, attacks, basically, right?
Exactly. So it goes back to the alloimmune thing. The mother is recognizing a platelet blood group on the baby's platelets, which she doesn't have, and she has an immune response against it, makes antibodies, and those antibodies destroy the baby's platelets. Exactly right.
Right. And so now there's varying degrees of compatibility and incompatibility. Can you give me a little bit more detail on what what the varying degrees are, and if they do or if they don't matter?
Yeah. So the reason that they matter is in relation to assessing the risk of NAIT reoccurring in a subsequent pregnancy. So at the moment, and I'm sure we'll come on to discuss this, there's no screening program for NAIT.
Right.
So the first indication that there's a problem is usually when a baby is born and found to have bruising or bleeding and a low platelet count, and the diagnosis is made. And obviously a really key question that families want to know is, well, is this going to happen again in the next pregnancy, or is this just a one-off? And this is where the inheritance is important. So a father may have a double dose of the platelet blood group, platelet antigen, or a single dose. So is the gene for the platelet antigen present in a double or single dose? So if it's present in a single dose, there's a 50% chance that the baby will have this platelet blood group. If the father's got a double dose, it means that the baby will definitely be affected. So the way that it works is that the mother must be double dose negative for this platelet antigen. She's completely lacking it. The father can be single or double. The father will pass on either if he's double dose, he's bound to pass it on to the baby. The baby will inherit one from the mother and one from the father. The one from the father, if he's double dose, it's bound to be positive, and the baby will be positive for this antigen, this platelet blood group, and the mother can recognize those platelets as foreign. If the father has only got a single dose, he can pass on either the positive or the negative. If he passes on the negative and the mother is negative, then the baby will have the same double negative that the mother's got, and the baby won't be affected because the baby's platelets are the same as the mother. Sorry, that's a very long and involved explanation, but I hope that's made it a bit clearer.
Oh no! And I think most of our listeners, don't have a genetics background or a science background, so that explains it perfectly. So having gone through the genetics, I know I always do the boxes when I have to explain it to somebody. I draw the boxes out and I say, okay, this is what I have. This is what my wife has. This is what our daughter currently may have. This is what our son certainly had, and so this is kind of the difference. The screening process for it, and then we'll get into why or why not the screening is done. But what does the screening process look like for individuals? I guess at this point, individuals who have had an occurrence of NAIT and are on a subsequent pregnancy.
Yeah. So at the moment, there's no antenatal screening for NAIT. So when there's antenatal screening for all sorts of different diseases, like sickle cell disease, but for NAIT, the first time a family have a baby, there's no screening for NAIT at all. So if it occurs, it occurs as a surprise, as it may have done for your family, Kyle, I guess.
Oh yes.
Yeah, and usually, as I've described, it presents with bruising or bleeding after birth. So that's a flag that this family is at risk for NAIT. And then there can be a discussion along the lines that we've just had about, what's the risk of NAIT going to be in a subsequent pregnancy, and think about what the options are for antenatal management. So the reason that there's no antenatal screening for NAIT at the moment, it's really because of uncertainty about the treatment for pregnancies where there is a risk of NAIT, because so if there was screening and a mother was identified because she has the correct platelet type and maybe because she has antibodies, we don't know what the best treatment is in that situation before a woman has had an affected baby. Most pregnancies at risk of NAIT will not result in a baby actually having NAIT with a low platelet count and bleeding. Most of those pregnancies where the woman is at risk will not be affected. So if we did a screening program and identified women at risk of NAIT, potentially we would be over-treating many women. And the treatment that we have at the moment with intravenous immunoglobulin is burdensome for the mother, is not without some risks and side effects, and is expensive.
Oh, yes.
And so those are the reasons that we're not doing a screening program for NAIT. We wait until there is the occurrence of NAIT. We obviously treat that baby to make sure that no harm comes. And then with subsequent pregnancies, we know that there's a high risk of NAIT in a future pregnancy. And then we manage the pregnancy with treatment to minimize the risk of damage to the baby. But at the moment, because we don't know how to manage we don't know how to identify those women that might be picked up on a screening program. We don't know how to identify those women who would be at risk of having a severely affected baby. So we're not carrying out a screening program.
Okay. So now, are there any theories or hypotheses at this point beyond, the standard the blood test that you will do on the subsequent pregnancies, and once you start piecing things together, are there some theories that are starting to emerge that there might be another factor that might play into potentially coming to an initial screening, or is that kind of that's still up in the air with research trying to put that piece together?
Yeah, that's a really, really good question. There is some research that is indicating that the strength of the antibody that the mum has may give an indication of whether the baby is likely to be affected or not. But the relationship between the strength of the antibody and the likelihood that the baby is going to be affected is not tight enough in the view of most countries to implement a screening program. So just to amplify that a little bit. So even the women who have a very strong antibody, that doesn't necessarily mean that the baby will be affected. And the other way around, there may be some women with low levels of antibody who will have a severely affected baby. So that's the problem. And so we're still in this situation where potentially, if we did a screening program, identified women who are at risk for NAIT, who haven't had an affected baby, potentially we'd be over-treating them.
Well, Mike, if you don't mind repeating that for a second, the connection had cut out for a brief second.
Okay. So the concern about the screening program is that without a good test to identify those women who would be at high risk of having an affected baby, then it's just not worth it at the moment, because we would be potentially treating a lot of women identified in the screening program who are not going to have a severely affected baby.
Right.
And the treatment with intravenous immunoglobulin, which we would use to treat women before they deliver, is burdensome for the mother.
Right.
It's not without risks, causes some side effects in some cases, and is expensive.
Right. Now, when the blood tests are drawn after, in the subsequent pregnancies, and there is found to be, at least a 50% risk, or, at the 100%, 50% incompatibility, or the 100% incompatibility. There's also an antibody presence test. So at different, from what I've read, at different times, I got to go back from what my wife's read and has shared with me, because she's definitely the more scholarly of the two of us. The antibodies can be present at different times. Now, is there any difference at 12 weeks if the antibodies show up as opposed to 24, as opposed to 32?
Are you talking about a first pregnancy or a subsequent pregnancy?
In the subsequent pregnancies, when all the blood work when all the blood work starts to flow considerably. Yes.
Okay. So really the testing of the antibody is the strength of the antibody is not important in terms of deciding the management of a subsequent pregnancy. Mm-hmm. What we do is to use other parameters, which is really thinking about going back to the history of what happened in the affected pregnancy, because that's a more reliable measure of when a subsequent pregnancy is likely to be most severely affected. So, for example, if the NAIT was just identified after birth and the baby didn't have severe hemorrhage, then we would start treatment later in pregnancy, in a subsequent pregnancy, than if the baby was severely affected, and if the baby had a hemorrhage in the womb before delivery. So the antibody strength is not useful to us in terms of determining our management in a subsequent pregnancy. We work much more on the basis of the previous history of hemorrhage and when the NAIT was diagnosed. Was it before or after birth?
Right. And for people listening, this is what's considered evidence-based medicine. And, and sometimes it can be hard to hear that, especially if you've lost a child to this, it can be kind of hard to hear that, all the treatment will be based on how good or how bad that previous pregnancy goes, rather than, you would intuitively think running the blood tests, going through these screenings, trying to implement screenings, and then it should be able to fix the problem. We're advanced in medicine, but from everything that we're talking about here, the unfortunate part is that sometimes the first pregnancy isn't going to work out, and that's how some people find out. And right now, it's almost like that's just that's the best evidence that we have for subsequent treatment.
I think we're talking about two different things here. One is the initial diagnosis of NAIT, mm-hmm. and the management of the first affected baby, and then the next issue is management of the subsequent pregnancy, and actually the third issue is the question of screening. Mm-hmm. So for the identification of the first baby, We do that on the basis of identifying a baby that has bruising or bleeding and checking the platelet count, and then doing the workup of the father and mother's platelets to check the platelet types and antibodies. For the subsequent treatment, as I've just described, we base that on the past history. So how severely was the baby affected, and was that before or after birth? And then the screening issue is that at present we don't have good enough tests to identify which women will have most severely affected babies, and without that we can't determine which women would benefit most from treatment, and we don't want to be treating many women at risk of NAIT who are not actually going to have a baby that's affected at all.
We've kind of made our way through like the 1, 2, 3s and ABCs of NAIT, but tell me, Mike, about the treatment, what it used to be like, if there was any before, and what it looks like now.
I've been thinking back to the first case that I saw, first family I saw with NAIT, which was probably about 30 years ago, and we had no platelet testing then, no way of finding compatible platelet transfusions, and certainly no antenatal treatment, and no way of providing much guidance to families about the risk in subsequent pregnancies. So we've come a long way since then. And the advances have obviously been in diagnosis, in the platelet testing, so that we understand what NAIT is about, and in providing the antenatal treatment for further pregnancies.
And so what is what's the current gold standard for the antenatal treatment right now? You talked a little bit about it, the IVIG.
Yeah. So again, delving back into history, when I first started with this in the mid-1980s, what we did was to set up a program of giving weekly fetal platelet transfusions. So that was very invasive, obviously, in that a needle had to be put into the umbilical cord of the baby, take a sample to check the platelet count, and then transfuse platelets to the baby. And we did that on a weekly basis. This was before we knew about the value of intravenous immunoglobulin. And that treatment was very, very effective, of giving weekly platelet transfusions to bump up the baby's platelet count, and that could do that weekly from around 20 weeks gestation right through to the time of delivery. But it was risky. Each time the transfusion was done, there was a risk of bleeding.
Right.
And a risk of causing miscarriage and early delivery.
Right.
And then some colleagues of ours in the United States, a colleague called Jim Bissell in New York, started working on intravenous immunoglobulin and steroids to use as antenatal treatment. And he found that was very effective, and although it didn't always bump up the baby's platelet count, it certainly prevented bleeding in the womb. And so many other centres, including ours in the UK, started to use that treatment, and that's the standard treatment that's used now. The timing of the start of treatment and the dose is dependent on the past history of NAIT. So the more severe the past history, the earlier the treatment starts in the next pregnancy, and the higher the dosage of treatments, and also consideration of the use of steroids in combination with intravenous immunoglobulin. But it is a very, very effective treatment, and the success of the antenatal treatment now is really, really very good.
Yeah, and that's what we've read both personally and professionally. The treatment right now is incredibly effective as long as you can get to that point. I know my wife. She's reached out and she's talked to quite a few people who a lot of their doctors, their maternal, their MFMs aren't too aware of what really NAIT is, or all the inner workings of it. So getting to that infusion part seems to be one of the biggest struggles. Let's see. My wife's kind of the producer in the background here too, so she kind of feeds me some questions as well. So a lot of women have questions about what happens after the baby is born. Like, is the baby given the platelets after they're born?
Well, usually. Yeah, lots of really good questions. So usually the platelet count will be normal.
Okay.
So the procedure after the baby is born is to check the platelet count and only transfuse platelets, which is the easiest treatment to do once the baby is born. It's the easiest way of getting the platelet count up quickly is to transfuse platelets, but only to do that if the baby's platelet count is low.
Right.
But in those circumstances, the baby's platelet count will be normal and won't need any treatment.
Gotcha. And then are the platelets, are those donor, or are those directly from the mother?
No, they're donor platelets.
Okay.
So we have the blood services around the world will identify donors who have essentially the same platelet type as the mothers who are affected, and so they've got the same platelet type, and their platelets are collected for transfusion for babies who have NAIT.
Okay. Perfect. So, Mike, to get a little bit more personal now, how did you get involved with doing this research, and what's your current role with all this? We probably could have started with that beforehand, but we really just dove right into it.
No, that's fine, Kyle. No, so I'm a hematologist. My specialist interest is in blood transfusion, in transfusion medicine. And those of us who are in that field often also have specialize in diseases of antibodies against blood cells. And one of the diseases with antibodies against blood cells is NAIT. And I got interested in NAIT because I started seeing cases when I was a trainee hematologist in London of NAIT. And at that time, there was very little that we could do in terms of testing or predicting risk in future pregnancies or antenatal management. And my hospital, we had a platelet antibody laboratory, so we would be referred samples from women with NAIT for testing for platelet antibodies, and we would be asked for advice about management. And so I got interested in NAIT, in the testing and the diagnosis. And then we developed a collaboration with another hospital in London to start the antenatal treatment program with platelet transfusions to the baby, where the baby was known to be at high risk of NAIT. And it's just gone on from there. I've had wonderful collaborations with people all over the world, and we've learned a lot from each other, and develop the treatment programs, the very effective treatment programs that we have today.
Yeah. And it's a pretty close-knit group of practitioners and providers that work with NAIT, so I'd imagine that you guys probably all over the world, you guys know each other pretty well at this point.
We do, and we don't often get together, but occasionally we get together at meetings. But we connect on conference calls and email. It's so easy these days. Oh, yeah. And we do our best to link with the patient support groups who provide a fantastic service for families with NAIT. So the program, the patient support group that I work with is NAIT.org, and I've done that through one of the leading people in that group who was a patient that I was involved with many years ago.
Okay, and you ran a half marathon for that group as well.
That's right.
with a pretty impressive time too, I think, right?
Well, I don't know about that, but it was great. It was great fun to do. I arrived on the day, and a number of ladies from that patient support group came. They gave me a NAITbabies.org T-shirt and cheered me along, and it was a great day, and actually it's got me into running, which is probably no bad thing for an old guy like me.
Oh, no, it's never a bad thing for anybody. So what are you running? Do you have any races planned right now, or what's your training looking like for that?
Yeah, so they have races in Oxford, which is where I'm based. So I ran a 10K at the weekend in 49 minutes, which was pretty good for my over 60 age group.
There you go.
And I'll do a half marathon in the autumn. Okay. And actually at the transfusion meetings I go to, we usually have a 5K run or something like that, and that's great fun to share with colleagues.
That's great. That's awesome. So Amanda's writing me another question here. Let me take a look here.
Yes.
Let's see. So just one more question regarding the treatment, because, with my wife at 28 weeks, she's going to be starting prednisone in addition to that IVIG treatment. What's the role of the prednisone? Is it about the effectiveness, or is it treating side effects? What's the role of the prednisone with that?
Yeah, it's to increase the effectiveness. Okay. So the combination of intravenous immunoglobulin and prednisone and steroids is going to increase the effectiveness of the treatment.
Gotcha.
This is part of a standard program that we're using for antenatal treatment of NAIT all over the world. It was formally developed by Jim Bassell's group. I'm sorry, the fire alarm is going off.
Not a problem.
I don't know whether you can hear it in the background.
Yeah. So do you need to evacuate the building?
I think somebody might come and knock on my door in a minute, but hopefully that's the explanation. So it's the combination of intravenous immunoglobulin at steroids at 28 weeks. Yeah. So the intention of that is to increase the effectiveness of the treatment.
Perfect. All right.
And I think I'm actually going to have to go.
No problem. I think that was probably the best way to end it anyway, with a fire alarm, with the Elvis has left the building type of thing. So, Mike, thank you very much, sir. I really appreciate it, and I know you have to go. So have a great day out there.
Every day, and for all the very best to you, Kyle, and what you're doing for NAIT families, and the very best wishes to your wife for her treatments and the outcome of the pregnancy.
Thank you very much, sir. We'll keep in touch. Have a great day.
Okay.
Bye-bye.
Take care. Bye now. Bye.